And with this, I would like to invite Dr. Emrah Celtikci, who is an associate professor at Gaza University, Faculty of Medicine, Department of Surgical Medical Sciences. Dr. Emrah, yeah, you're visible. Please share your slides here. That's it. Thank you.
Yeah, okay. Hello, everyone. Can you hear me? So is there any problem with the speakers?
Yes,
No,
we can
it's
hear
you're
you.
audible and the
You can
screen
hear.
is well visible. Yeah.
Yeah, great. So hello, everyone. First of all, hi to everyone from Ankara, Turkey. So there's a thunderstorm out. So if you hear any thunder noises, don't worry. I'm in a safe place. So the thing is, I will talk about the anatomy of the venous drainage of the brain, and that's a long talk, and I don't like long talks. So basically, I will talk about something as I specify on some subjects, and I will not talk about some particular parts. So first four slides are a little boring because I don't like too many written slides, but at least we should classify what we will talk on and the basic classification of the venous system. And the venous system is how can we classify it? The cerebral veins, dural venous sinuses, ophthalmic veins, diploic veins, and emissary veins. But in this presentation, I will particularly talk about not too much about the cerebral veins, but I will focus a little on dural venous sinuses because, as far as I guessed, previous two speakers had to talk about deep cerebral veins, because if you are talking about the ventricular anatomy, then you should talk about some of the deep venous structures. And my guess was true, especially Dr. Barış Küçükürük did a very great presentation showing the importance of the deep cerebral veins and the positioning of the foramen Monro and the ventricles and everything else. So that was good. So we should talk about veins and the deep cortical veins and the deep veins, superficial veins. So what we are talking about? We will start with the superficial veins, then we will go into the deep veins, then we will talk about especially the dural sinuses, and somewhere that I want to talk particularly on somewhere that most of the time we pass very quickly in venous anatomy, which is the cavernous sinus and especially the basilar plexus. For example, in a diagram like that, you see cavernous sinuses shown like that, but it's not correct, and there is no basilar plexus here. But we know there's a drainage in basilar plexus. So the one of the boring slides, the superficial, which are the cortical veins. So we all know what the cortical veins are. When we open the dura, those are the veins that we deal with. And also there are some middle cerebral veins, and the most important superficial middle cerebral vein is characterized as Sylvian vein, and the infracerebral veins, which drains into the superficial cerebral vein and cavernous sinus, superior petrosal sinus, transverse sinus, and this kind of skull base parts. So from now on, I will show some anatomical dissections in which some of them we used in this publication, and some of them we did the dissections for this publication. So here we see the superficial veins, but in this particular dissections, as we see the occipital vein, posterior parietal vein, anterior parietal vein, and other frontal parts, and the Sylvian vein. But the thing is, that doesn't represent the anatomical localization of the veins. Yes, the localization, I mean the topography is right, but first is first, we should understand the superficial veins mostly goes through intraarachnoidal. So when they try to move along into the dural sinuses, they should do something. So what they should do, they should they should penetrate the arachnoidal membrane. They should be extra-arachnoidal. Then they should go into the dural sinuses. As we see here, look. So inside it is intra-arachnoidal, and then the dural that we call the bridging veins most of the time. Drainage is into the dural sinus, but in order to do that, that vein should penetrate the arachnoidal membrane and go extra-arachnoidal, and in that way it can perform its drainage into the arachnoidal veins. So the superficial veins from frontal to the posterior, from frontal to the occipital, as you see, the frontal part is a little low on venous drainage, not low, let's say, but from frontal to the posterior, the calibration of the veins are increasing, and as you see here, especially the anterior parietal vein and posterior parietal vein is far more than posterior, we think, but they are important veins. They are important veins because they are most of the time doing anastomosis with the veins like lateral part of the brain, like trollard, or there's sylvian vein anastomosis. And the second part is when we want to do an interhemispheric approach from posterior, like I will show you next slides. We should do a surgical planning to calculate the difference between two veins like here, posterior parietal vein and occipital vein, or anterior parietal vein and posterior parietal vein. Because this is important, because if we are planning to do, especially in the interhemispheric approaches, and if we go this much posterior, these veins are, we cannot sacrifice these veins. It will be catastrophic. So in order to do this, surgical planning and to understand the posterior part of the superficial veins are very important for surgical planning. Why this kind of surgical planning? Because let's say we are trying to perform a surgical approach to the pineal region, to the falcotentorial junction, which we will make an interhemispheric approach. The veins, the superficial veins, the cortical veins became one of the most important veins, because when we are doing the approach, as well as I will show in the next slides, there's vein of Gallen's, the straight sinus. Okay, we know where they are. But the thing is, during the planning, we should calculate, we should precise where the bridging veins are, so we will understand where the distance between two drainage veins. That's very important. And then we will go for the deep cerebral veins and dural sinuses. I'm not differentiating deep cerebral veins and dural sinuses because they are all interconnected, especially most of the anterior parts. So here we see again, the supraesophageal sinus and the deep cerebral veins. But if we go deeper, let's see here on the bottom right, which is the D section. The first is here we see the vein of Gallen, the straight sinus, and the splenium part of corpus callosum. So again, in the midline, we are dealing with, in the sagittal section, we are dealing with the deep cerebral veins, and especially their branches are very well described in our previous speaker with the Barış Küçükürük, which I will not go into the details because we have things to talk. And here we see another anatomical dissection. Again, the same part, which the straight sinus, and the vein of Gallen, and the splenium part. So as you see, this confluence here is very anatomically very it have neighboring structures, and the splenium is one of the main landmarks. But the thing is it the only landmark? So here we see, okay, here the approach, interhemispheric approach in the real case, and the left first two top pictures are anatomical dissections. So let's go deeper. So here we see an interhemispheric approach in which we see the posterior falx, the vein of Galen, and the two posterior cerebral arteries aligning together. And on the right, so this is interhemispheric, but here, this is an endoscopic view, and the approach is completely different. Here is the interhemispheric, and here is the supracerebellar infratentorial approach, and endoscopic view, and we see the vein of Galen and the basal veins, and including the posterior cerebral arteries again aligning together. So this drainage is very important, as you see, both in supracerebellar infratentorial approach and also in interhemispheric approaches. So we are going fast forward because, you know, I'm pretty sure it's getting late in every time, and I don't want to talk the same things that previous speakers told. So the other thing that many people doesn't mention too much, which is the venous system of the skull base. So the venous system of the skull base is when we ask people, especially my fellows and observers, most of the time they only mention the cavernous sinus. So cavernous sinus, yeah, we know, and the intercavernous sinus and the basilar plexus are in fact the part of the same drainage system. So which means the cavernous sinus, the basilar plexus, which is behind the clivus. The basilar plexus is the venous plexus behind the clivus. The cavernous system, the basilar plexus, and intercavernous system is in fact all together, connected to each other between the layers. So we should understand, especially for from the point of endoscopic skull base, we should understand the importance of this venous drainage, because most of the time, sometimes my young colleagues are consulting me or asking me that they have problem with dealing with the venous bleeding in this region. But the thing is, it's not only cavernous sinus, or it's not only the basilar plexus. They're all interconnected. So what we know about cavernous sinus, the cavernous sinus, in fact, a potential some void, but not venous blood, and it's between two layers, like a pyramid. The top of the pyramid is one part is going back and one part is going down, and the one of the largest surface is we're facing during the endoscopic skull base surgery. So this part is not only a venous system, but also an anatomical landmark, which includes the sixth nerve from the bottom, and the third, fourth, and the fifth, sixth nerve from the lateral sides. So it's very important to understand it's not only a venous system, but it's a venous system, and it's a venous anatomy. It bleeds when you open, but it's also something you deal with, like a anatomical structure, which includes all these anatomical, especially the nerves and the arteries. So let's give an example here what I'm saying. So here the video will start very quick, and it's just summary video. We will be looking with the 45 degrees endoscope into the cavernous sinus. So on the lateral side, because we are looking into the cavernous sinus, on the lateral side, I will show you before beginning of the video. On the lateral side, on the right side, there will be the cellular and supracellular part, but we will be focused on the cavernous sinus, and we will see what is the venous bleeding. So here is the cellular supracellular part. Here is the cavernous sinus part, and this will be the ICA. And let's see what's happening. So you see, that's the venous bleeding. So if we are talking about the venous anatomy, the venous drainage of the brain, and we should have a venous drainage. Here you see the ICA going like that. And on the wall, let's go back again. On the wall, there will be cranial nerves, you see, third, fourth. So there's a bleeding. This bleeding is not coming from here. Bleeding is coming from here. This is venous bleeding. So you see, it's bleeding like that. When we apply hemostatic agent, the venous bleeding is more, nearly every time easy to manage. You see again? The cranial nerves. Okay, so, but there's a paper from Pittsburgh group, and they defined the ligaments of the cavernous sinus. And cavernous sinus is a venous system, and there's ligaments are defined it. But in pituitary cases, you cannot see these ligaments as they mentioned. So these two papers, the medial wall of the cavernous sinus papers, are defining the ligaments, their importance. But let's be honest, during a random pituitary surgery, which invades the cavernous sinus, we don't see those ligaments. But where are those ligaments if they are mentioning this in the anatomical study? So it changes according to the nature of the tumor. So you see here a cavernous sinus tumor, which is a vascular tumor, which is a cavernous hemangioma. So now we are dealing with a cavernous angioma in the cavernous sinus, which is the one part of the drainage of the skull base. So what should we do? So the tumor is like that. And hemangioma and the ICA are aligned like that in this particular case. And then when we open the dura, we will see the hemangioma and we will see the pituitary like that. So when we try to resect the hemangioma, what happened in this case? The patient was lying in supine position and the hemangioma was pulsating like hell, and it was getting bigger and bigger and bigger. Then we elevated the back of the patient in a reverse Trendelenburg, and it gets smaller and smaller and smaller. So why I'm saying this? I'm saying this because especially in skull-based cases, the venous anatomy, even though when you know the venous anatomy, the control of the bleeding sometimes becomes problematic. The venous pressure can be high. So what I recommend in every single neurosurgeon here, elevating the back or reverse Trendelenburg position decreases, especially the venous bleedings from cavernous sinus and basilar plexus. So here we see that case, the same case. So here we are dissecting, and here you see the ligaments mentioned in that paper. And we are now talking about ligaments in a venous drainage system in which there is ICA and the cranial nerves. So if we are talking about the venous system of the brain and the skull base, cavernous sinus, from my point of view, cavernous sinus is the part that most of the time neurosurgeons are not mentioning, but we should talk about that. So here we are dissecting, and as I say, the back is elevated, so that's why this tumor is like that, squishy, it's soft, because the venous pressure is low. And we keep dissecting. ICA is here. Look, ICA is here. We kept dissecting. We cut all of them. Most of the time, the worst ligaments are between tumor and the pituitary. Now that's the ICA. There's the pituitary, and here is the cavernous sinus, you see. So, cavernous sinus, venous drainage, pituitary, ICA. So, as you see, cavernous sinus is a part of the venous drainage. But here's the thing. For example, if you coagulate or, just destroy the deep cerebral veins, it's most of the time that can happen, some catastrophic events. But if you apply a hemostatic agent into the cavernous sinus, nothing happens, because it's all about the amount of, not only about the amount of blood, but it's also about which part of the brain it drains, the venous drainage it makes. So these are the two papers we published about our cavernous hemangioma resections. And the second thing is, again, so we talked about basilar plexus. Now we are looking to the clivus, anterior part, endoscopically. So this is the basilar artery, as you see. These are the cranial nerves. Here is the sixth. But as you see, there's blue silicon. So what does it mean? Why there's blue silicon here? Because the reality is posterior of the clivus is filled with, from superior to inferior, filled with venous blood. It's filled with too much blood. But do we see it in every single case? So because there's venous drainage here and it's part of the venous system, but do we see it? So in cases like that, which are invasive cases, these kind of cases, I'll just fast forward a little. So let's see, this is the sella, here is the clivus. So when we remove this bone, what we are expecting in normal conditions, we are expecting, moderate pressure venous bleeding. Because this part of the skull base is being drained a little different than the other parts of the brain. So we are drilling. Yeah, we kept drilling to the clivus. You see there's a little bleeding, but not that much. This is not the expected bleeding. The expected bleeding is too much. And here is the median nerve, by the way. And median nerve is very important in skull base operations, endoscopic ones, because that's how we define where the ICA is ended. So we are opening the dura, and the bleeding is not too much because that's a petroclival meningioma. And the petroclival meningioma means it's petrous and clival. So the tumor already invaded the basilar plexus. That's why we don't see too much bleeding. And what we are doing, we are using ultrasonic dissectors, we are using bipolars, we are making the tumor shrink. Let's go a little faster. And here you see the vertebral artery. By the way, that vertebral artery is the contralateral one because the tumor pushed it. We keep decompressing the tumor by using the ultrasonic dissector. But you see the venous bleeding is not that much. I do not expect that. Because that's an invasive tumor. Like which other one? Like the chordoma. So here we see the pons and the arteries, and this patient did well. So let's go to the other case. But this case, let's talk about this case. This case is epidermoid tumor of the cerebellopontine angle and into the Meckel's cave. So these are the post-op views, but this is not an invasive tumor like a meningioma or chordoma. So now we are dealing with the venous drainage of the skull base. What does it mean? So this will be fast forward. Just I will show how it bleeds. And look here. It's bleeding. It's very small, so we should do it fast. And you see here the hemostatic agent field. Now we can work much more comfortably. If we don't do this in the early stages of this surgery, then we will deal with too much bleeding. Now I'm using a little more than the previous case, a little more bipolar coagulation. Then what will we do? We will open, then we will resect. Here, just wait. And this is the basilar artery. We are in the cerebellopontine angle. But in this case is different than the previous case because it's not invading the skull base venous structures. So what I'm trying to say here, there's a lot of talk about the anatomy of the brain and anatomy of the skull and everything else. But as some of you know, I do mostly endoscopic skull-based surgery, and all the speakers before me already talked about, especially the thalamic veins and the deep cerebral veins. That's why I focused on mostly the venous drainage of the skull base, which most of the time doesn't mention, even not in the diagrams, but there is a huge venous drainage in the skull base. So these are intraoperative MRI case series papers, and these are our from last year our orbital endoscopy papers, and these are multi-center papers, both with the North American Skull-Base Society and the Turkish Neurosurgery Society, and the cases that I showed you before, and we reached already more than 3,000 cases so far. And next week, probably we will operate our 91st and 92nd chordoma cases. So I hope I am faster because I really hate long speeches. So thank you, everybody, for your kind invitation. That's it. Thank you. So
Thank you very much.
Yeah, thank you, Emrah, for a very lucid talk, and it was fascinating to see you work through endoscopic routes into the skull-base venous system. A very beautiful work and very well elucidated. Well, this brings to the end of the three great talks which we listened this night, and then let me invite the audience for any question answer. Dr. Ahmed, did you see any questions in the chat box?
I don't see any question in the chat now, but I have a question for Dr. Alberto Filetti. Dr. Alberto.
Yeah, please go ahead.
Okay. In some cases during endoscopy, the foramen of Monroe will be small or maybe even not very wide, so you can enter by the endoscope to the third ventricle. Do you have any idea or tricks how to identify the size of foramen of Monroe in radiology, or you do that only during surgery?
Yeah, it's a good question. Thank you. So, as you said, sometimes we have atresia of the Monroe foramina, and there are some cases of mono or biventricular hydrocephalus. So, in those cases, radiology is very helpful. It's very clear from the MRI when the Monroe foramen is almost totally closed. In those cases, we perform monroplasty and septostomy. In other cases, there is actually not a real atresia, but there is a small Monroe foramen. So in those cases, I do use both rigid and flexible endoscopes in the ventricles, but if I have to cross the Monroe foramen, I always prefer the flexible endoscope because the diameter of the flexible scope is very tiny, very small, and I have never had any problem with even with small Monroe foramina. So as long as you have a flexible scope, you don't have to worry so much in crossing a small foramen of Monroe.
Thank you very much.
And in case you have a rigid only, I think it's a good idea to use neuronavigation for a good trajectory in those cases.
If I need to do
Well
dilatation
said.
of the foramen of Monroe, do you have any trick or do you have any method to avoid complication or injury to the fornix or
Yeah.
other structure?
Right. So there are some areas which are more risky, and those areas are the posterior part, which is closer to the interior cerebral vein, and the most medial part, which is the border with the columns of the fornix. So in those cases, when I have to do a monoplasty, I pay attention to avoid those areas if possible when I enlarge the monoframen.
Thank you very much.
In fact, just a word of caution, foramen of Monroe is located very near to the genu, the bend of the internal capsule on the lateral side. It is just immediately located to it. So that's one thing which we also should be aware of when we are going through the foramen of Monroe. Uh, well, any other questions, Dr. Hamid?
Okay, I have another question for Dr. Emrah. During either microscopic surgery or endoscopic surgery, if we have a cavernous bleed and you have to do inject some hemostatic agent, is there any specific hemostatic agent preferred, and is there a specific angle, especially during microscopic surgery? Do you have some specific angle to inject
Yeah,
to
very good
avoid any
question. That
complication?
angle thing is very good question. First, I will start with the angle. Uh, my surgical nurse always prepares the tip of the hemostatic agent a little angled, so it's not straight, but the tip, only the tip. The second thing is, maybe you're asking, so if we're applying it to the right cavernous, should I apply it from the left nostril? Most of the time, that's the way we do that way. But the thing is, not particularly, because cavernous sinuses are not too far away from the midline. So you can use the same nostril, but what we do is just making a little angle to the tip of the hemostatic agent. And I don't want to give names of the hemostatic agents, but we are using the, what is in the market, not something different. So there are some companies providing these hemostatic agents, but nearly every hemostatic agent we tried and they all worked well. So, you can use anything.
Thank you very much. I'll see if there is anyone of the audience. If I have any question, please, even you can ask directly or ask in the chat.
I have a question to Barış Küçükürük, in fact.
Go ahead, Doctor.
Dr. Küçükürük, maybe you should mention something about the young neurosurgeons, what they should do if something goes wrong, especially with the deep cerebral veins. Let's think like a bleeding started. What they should do? What's your approach? Because most of the time, as I know from my residents, they tend to coagulate directly to the every single bleeding they see. But I think maybe you should mention something about that.
Yes. Yeah. Great question. Thank you. So veins are not like arteries. So there is actually for a vessel, particularly I'm speaking on the arteries, you can either coagulate all of the artery, or you can just put your bipolar next to it, and with a low coagulation, you can make it squeeze. But this won't work with veins due to the absence of the muscular layer. So if you bring your bipolar and make it work around the veins, they will close. And with deep veins, it will be catastrophic. So the best thing, step by step, would be first putting a cottonoid and then wash the excess amount of blood first and then try to find the exact point of bleeding. And then there are steps you can do. If you are very, very lucky, just a small amount of Surgicel, not fibrillar Surgicel, a regular Surgicel would work. Or you can put some fibrillar Surgicel and take the fibrin glue, the T-cell we have in Turkey. But as you know, the nurses mix them with each other. It's two parts, but you can just take the fibrin part and put just one drop or two drops with a dentate needle on top of the fibrillar Surgicel. So again, the first way is just putting a regular Surgicel, but probably it won't work. Second, fibrillar Surgicel, and on top of it, some drop of fibrin. But my way of doing it is I always cut a very small muscle, just around the size of a rice, let me say, very small, just 1 or 2 millimeter, and put it on the hole on the vein, and then put T-cell on it. It always stops. And I also done a couple of times fluorescein video angiography to see if the vein is still working, and it was working. So my way of doing is, again, there is 3 ways, but my way of doing is just put a very small muscle on top of it and put fibrin glue on top of it. So it always works, always. But if you can't find the hole, then some Surgicel may work, but no coagulation, for sure.
Thank you.
Anyone have any questions, please? Someone here in the chat asked Dr. Alberto if you can send him the book of neuroendoscopic surgery. Is that possible?
Yes, I already sent.
Okay, thank you. So I guess there is no more questions here in the chat. Dr. Amit, do you have any comment or any remarks?
Yeah, I actually thoroughly enjoyed the whole talk by Dr. Beres, Dr. Alberto, and Dr. Emrah. Well, they beautifully had presented the whole talk about the ventricles and the venous system. And just to add the historical meal to it, it was Herophilus from Greece towards the region of Bosporus. That was in the year 335 BCE, when he first mentioned about the brain ventricle anatomy as well as the venous sinuses. And somehow we are talking on these two issues in the same session. So Herophilus is credited to name the choroid plexus. So this is how the whole history of ventricle and the deep venous system had been so fascinating throughout these years to these neuroscientists. Well, I'm truly appreciate the effort these speakers have put in making the presentation, and very clearly and very simply putting in very complicated or complex task of making the anatomy clear to the young neurosurgeons across the world. Thank you, everyone, for putting the things together. And thank you, Dr. Ahmed from Yemeni Neurosurgical Society, for bringing us all together in this platform.
Thank you very much, Dr. Amit, and we are honored by your participation, all Dr. Amit and Dr. Baris and Dr. Alberto and also Dr. Emrah. And thank you for our speakers for this fantastic presentations and very clear and comprehensive information. And thank you, Dr. Amit, for this nice moderating of this session and enriching the discussion. And I think by this we can conclude our 10th session. So if there is no any remarks or no any questions, I think we can conclude and close this webinar.
Thank
So,
you.
thank you all for
Thank you.
Thank you.
participating.
Thank you very much.
And
Shukran. Assalamu alaikum.
wa alaikum salam, shukran, doctor. So I hope you can join us all in more presentations and more lecture like this. And thank you all. And we can conclude our film session. So goodbye.
Thank you all.